By the time everything is said, I welcome you. Welcome you to this space of learning something which is evolving, growing, the space of creation as it started with. Here I am to talk about genetics of infertility. So, infertility practice in itself, when we talk of infertility from the advanced perspective, it is not very old. Genetics also is very recent. It is not very old. 2-3 decades back, we didn't have much of the idea about what genetics is. Am I audible to the last? Okay. Fully. So when we talk of fertility, what are we talking about is life passing from one to the next generation. And what is life all about is the eggs and sperms containing the content that is genetic material. Anything going wrong with that is basically the reason for infertility in most of the cases. So it can be, so we are going to look at different reasons of infertility and all that. But when it comes to, principally when it comes to reproduction, it is all about the genes and the chromosomes, right? That is what we have inherited from our parents, they have inherited from their parents. So, to talk about genetics in context of infertility, I'll be talking mainly about the, you can say the errors which are responsible for infertility and the errors which are responsible for creating the abnormal conceptuses leading to abortions and creating the abnormal baby births. So let us go in. So we all are aware of definition of infertility, right? As per WHO, infertility is defined as a disease of reproductive system. It is a disease. It is defined as a disease of reproductive system, defined by the failure to achieve clinical pregnancy after 12 months or more of regular unprotected sexual intercourse. Divided basically into two types: primary infertility and secondary infertility. Primary infertility is delay that occurs in conception in couples who didn't have any child or who didn't have any pregnancy earlier. Whereas the secondary infertility is the delay occurring in conception in couples who have had at least one previous pregnancy, although it may not have continued and resulted into the live birth. So if we classify the types of pregnancy, we can classify it male infertility, female infertility, unexplained, and mixed infertility, wherein both male and female factors are there. So you can see here 30% in both male and females are responsible exclusively, whereas 20% males and females are responsible for infertility in common, and 20% of infertility cannot be explained yet. Though we have so many advanced technologies and investigations available, still we cannot identify causes in about 20% of cases. What is the impact? So if you look at the overall burden of infertility in the world, you can see it is about 48.5 million couples or people in the world having infertility. In countries, developing countries, and even in India in certain parts, the incidence is ranging from 1 in, you can say 15% to about 25%. So 1 in 4 is said to be the incidence in some of the regions. And what are the different causes that we all are aware? It can be any structural abnormality there in the reproductive system. It can be any infection, it can be any systemic disorder, it can be lifestyle even, it can be genetic also. The only thing from genetic perspective that I emphasize mainly all the time is the purpose of infertility is definitely for a couple to have a baby, but absolutely healthy baby. It's not only pregnancy, accomplishing pregnancy, it's continuation of pregnancy and having a healthy baby birth. In cases where there is a genetic error responsible for infertility, there are two risks. One is the discontinuation of pregnancy, loss of pregnancy, miscarriage. And second is having a birth of the abnormal baby. These are the dangers of the advanced technologies if these are not seen from the genetic perspective. So if you look at the genetic causes, then genetic causes of infertility in case of women and men. So the most common causes of infertility in case of women, you will see these are polycystic ovarian disease and endometriosis. Polycystic ovarian disease, PCOD, has become one of the very common concern in girls and the pre-marriage women, and is said to be one of the most, you can say, the biggest culprit in the world of infertility. and second is endometriosis. Both these conditions are said to have a genetic element. These are multifactorial, so there is genetic element also and non-genetic element also both. The other causes of infertility, what's happening? The close connection? Okay. The other factors which are genetic factors which are responsible for infertility are, here the list is given. Premature ovarian failure. Again, in the recent years, we are seeing that most of the girls are experiencing this at early age. Most of the women by the age of 35, they have very, you can say, a low reserve, ovarian reserve. What could be the reason? That's a big question to answer. That we're talking about the lifestyle and the food and the thought processes and the exposure to a number of unexpected and you can say like mobiles and videos and all those kinds of things. Even your thought process and the beliefs, they have impact on this. So early ovarian failure is one of the biggest culprit again in the world of infertility. Turner syndrome, though it is not very common, but it is one of the common conditions, one of the important conditions in infertility. Fragile X associated primary ovarian insufficiency. This is one condition wherein you can see the disorder inherited. Fragile X is said to be one of the most dangerous genetic disorder, the genetic condition which is seen inherited, right? Women usually doesn't have the expression in the form of mental retardation. Women being carriers for this, but they have the expression in the form of infertility or the ovarian failure. So this is one of the basic investigation in cases of infertility with, you can say, the primary ovarian insufficiency. Kallmann syndrome is one of the genetic disorder with anosmia and you can say the ambiguous genitalia. Congenital adrenal hyperplasia, sickle cell disease, galactosemia. There are a number of conditions. There are some of the conditions I have mentioned here which are responsible for the infertility in case of women. In case of men, so the most common condition that is reported in genetics regarding the infertile men is Klinefelter syndrome. But it's not that commonly seen. Like as a geneticist, I am practicing for the last 25 years. Most of these people don't reach the genetic clinic. I don't know what the reason is. So when the patient comes in an infertility clinic, especially for the treatment, the first thing that we come to know is from the male side is the sperm parameters. Whether it is oligospermia, azoospermia, pteridospermia, the combination of that. And in these cases, then we go for the genetic investigation depending on what the seminal parameters is. So azoospermia, oligospermia, the XYY syndrome, double Y syndrome we call. These are the commonly seen conditions which are responsible. Then there is Y chromosome microdeletions, testicular disorders of sex differentiation, Kallmann syndrome, and there are so many other genetic conditions in which I would like to mention about the cystic fibrosis, beta thalassemia, which are common, then sickle cell disease is common, androgen insensitivity is common, congenital bilateral vas deferens absence, which is caused because of cystic fibrosis. These are the common conditions which we see in practice, and these need to be investigated in cases of male factor infertility, wherein we have azo or oligospermias. Okay, so if we classify and group the different reasons for infertility, we can classify them into 4 categories from genetic perspective: hypothalamic, pituitary, gonadal, and ovarian tract. So if you look at the hormonal tract, hypothalamo-pituitary gonadal axis, and this is a hormonal flow which ultimately is impacting the fertility manifestation on the receptors. So these are 4 levels, 4 compartments. If you look at this compartment one by one, in the hypothalamic compartment, there are certain conditions. Some of the conditions I am mentioning here. Cal1 gene, which is the X-linked recessive disorder. You will see there is a hypogonadotropic hypogonadism, and it leads to infertility because of the reduction in the testosterone level. Another gene that we know is ASC gene, which is again X-linked recessive disorder and results into congenital adrenal hyperplasia. And through the negative food peptide packs, they are impacting the production of testosterone and causing the male infertility. Also, these are responsible for infertility in females also. At pituitary level, you can see the gonadotropin releasing hormone receptor gene GnRHR gene. It is autosomal recessive and usually impacts the gonadotrophic releasing hormone receptor. So you can see here the image impacting ultimately the release of FSH and LH hormones. The genes responsible for production of any of these gonadal hormones like FSH, LG or SCG beta, these also can result into the infertility. Gonadal factors. There are a number of genes involved in the development of the gonads and the development of the gametes. And you can see here some of the genes mentioned. SOX gene, WT1, which result into sexual ambiguity and infertility, and number of genes which are involved into the formation of the steroids, which have really very poor prognosis and require ultimately the donor insemination. There are sex chromosomal causes and mainly X chromosomal causes like loss of whole of the X chromosome, or as we have seen earlier, the cases of the females with premature ovarian failure. Partial deletions of X chromosomes, here especially these three sites are responsible for the premature ovarian failure: XQ11, XP21 and XQ13. These are the putative sites for the premature ovarian failure. And then one more region is X26, which is putative region for premature ovarian failure. And then cases with the X chromosome and autosome translocation, where one part of the chromosome, the X chromosome is, you can say, cut and it's translocated to some other autosome, are also resulting into infertility. In case of, so here are some of the conditions like fragile X condition that we have seen earlier, resulting into the premature ovarian failure. Other chromosomal causes like Klinefelter syndrome or translocations, and single gene disorders which mainly involve the genes of the Y chromosome in case of male. SRY gene, which is the gene responsible for sex determination in males, and the genes which are responsible for formation of the sperms, what are called as the age factors A, B, C and D. So deletion of any of these genes will also result into infertility. Okay. So the main purpose of the genetic evaluation in cases of infertility and reproductive failure in reproductive medicine is, one is identification of the infertility causes. So as we have seen, there are a number of other reasons for infertility. So before infertile couple is referred to a geneticist, already all the basic investigations are done. Hormones are done, the reproductive tract is checked, imaging is done, or the basic hematological investigations are done. And then the patient, when everything else seems to be normal, then the case is referred to a geneticist. So in all such cases, the basic purpose is to actually diagnose whether some genetic error, genetic factor is responsible for the infertility in the given couple. To answer the questions, is genetic factor responsible for the infertility, and is there a risk of inheriting that disorder in the subsequent pregnancy if the couple conceives with the advanced reproductive techniques? Second, so the second purpose is identification of genetic diseases which are transmittable to the subsequent generations. So in cases where the genetic problem might not be responsible for infertility, but there are associated genetic problems which can be inherited in the subsequent generations. So identifying such genetic factors, especially the monogenic disorders and structural rearrangements in the chromosomes which can be inherited to the subsequent generations, are to be identified. And the next purpose is optimization of the assisted reproductive techniques. So whatever technique you are using, whether it is IUI or IVF or XC or the other techniques including PCD, whether there is a risk of inheriting a particular condition in the subsequent generation, and what are the chances of having the pregnancy and the live birth in a particular case. This can be determined by using the diagnosis of genes and chromosomes. So if you look at the overall importance of genetic evaluation in cases of infertility, actually the potential lies in its potential to significantly impact an individual's or couple's ability to conceive and to have healthy offspring. The ultimate purpose is to have a baby, the healthy baby delivered completely. So understanding genetic basis of infertility gives you diagnosis for sure. It helps you to guide the treatment, what modality of treatment is to be advised to a particular family. It predicts the risks of miscarriages, risks of failures, risks of having the abnormal baby births. It facilitates the genetic counseling. and ultimately it helps in the research in infertility. What tests can be done? So depending on the case and depending on the manifestation, the phenotype, different modalities of tests are available and this can be prescribed. So karyotype is a commonly advised test where the chromosomes are studied. Then the chromosomal microarray, you are studying the chromosomes only but at a much deeper level. And then we can study the genes also. It can be a single gene, it can be a panel of genes, it can be all the genes, it can be a complete genome. So there are a number of different genetic panels available for today. So we can test a particular specific gene, for example, thalassemia. We can test for a panel of genes, for example, mental retardation. We can test for the clinical exome, which gives us the idea about the different pathogenic genes. And we can test for the whole genome sequencing, wherein we can identify all the genes, including the variants of uncertain significance. Going beyond that, we can even test for the whole genome, wherein each and every word of your script is read. So these are the different tests available. Depending on the need, this can be prescribed. And once the tests are done, what to do with those tests? What is most important part of the infertility treatment? So one part is the physical part wherein having a baby is involved and doing something in the laboratory or injecting certain drugs. This is the physical part. The most important part of infertility treatment is counseling. How you talk, what you talk, makes a huge difference in the outcomes. It makes a huge difference in each and every step. So that counseling, which is a regular counseling by the gynecologists and infertility experts done. Similarly, in cases of genetics, whether it is infertility genetics or other genetics, counseling is the most important aspect. So when you are evaluating, there are the different steps given here. When a patient comes, the first thing is to get the history in detail, to chart out the pedigree, first step. Now once you do that, you get a lot of information, whether it is inherited, whether it is passed from first one to the next generation. Then you analyze and interpret the pedigree to get to know whether this is inherited in a particular fashion, particular pattern is there, right? And then you can evaluate whatever record is there, the patient has brought number of files and all that record you go through, and then you come to the probable diagnosis. Does it look like to be genetic in origin or non-genetic in origin? And if it looks like genetic in origin, then you can go for the prenatal, the genetic testing. So before you do the genetic testing, again you need to counsel, which is what we call as a pre-testing counseling. Pre-testing counseling is very, very important, explaining about what the tests are and what can be expected at the end of the tests. Then you do the tests, and after the tests are to be interpreted. Now one thing I would like to emphasize here very firmly is, in all the countries, especially in India now, so many companies are coming there in the market. Companies which are doing the testing. These are the machines who do the testing. There are people who invest. There are machines which are doing the testing. Sample goes to the machine and machine gives the data. In a clinic, there is a patient who is having a lot of worries and doctor says something and he gives blood. There is a huge gap between that sample collection and the machine doing the data analysis. This has to be connected. This connection has to be done by the physician. This is the most important aspect of genetics. Otherwise, if it is not properly connected, it is going to create a chaos. That is what is actually happening right now. Huge data is created every day in the country, with a huge burden also created because of the data created, simply because doctors do not understand that, patients don't have any idea about, and the companies who are testing, they don't have why this test is done. So the most important aspect of this testing, which is generative, is huge, the costly investigation, right? And it has got a huge impact on the family and the not only the couple suffering, but the whole family. So it has to be properly interpreted and counseled. So that is the most important aspect of this. So what are the other factors which are involved in genetic counseling and infertility, especially talking about the implications of the genetic errors in syndromic or non-syndromic genetic errors identified. So what is the implication of that on the couple and the family? Informing if other family members are at risk. So maybe the couple, a partner or both are carriers of a particular genetic disorder, and their other siblings or other family members are also at risk. So they need to be addressed and counseled properly. Explaining about the reproductive options. So what to do next? They want a baby, absolutely normal, healthy baby with the optimum outcome. So here are a number of options, whether it is IVF or IUI or ICSI. And what are the success and failure rates? What are the different technique used? What are the limitations of the procedures? Are there any risks involved? Are there any preventive measures available? So all that involves in genetic counseling. Explaining about what prenatal diagnosis is in cases where there is a higher risk of having the baby with genetic abnormality, explaining about the prenatal diagnostic procedures and offering those procedures and explaining everything about the risk involved and the accuracy of the tests. Risk and implication of transmission. So if a father is, for example, carrying a mutation in the Y chromosome, he is infertile. So if his sperms are used in the procedures, will the baby be born with such mutation and will the baby be infertile again is a question. There are a number of such questions wherein there is a possibility of the baby also having the similar condition as the baby grows. Psychological and ethical implications. So these are some of the issues that we need to investigate. So I will not be going through this, just you can look at if the basic work is done in a female. It's a female infertility workflow. In a female you do everything. You do the regular physical examination, you do the imaging modalities and then the hormones. In case of females, if there is any hormonal imbalance, yes, there is hormonal imbalance. Then in that case, it could be any of the conditions on the right side. You can see hypergonadotropic hypogonadism or hypogonadotropic hypogonadism or adrenal hyperplasia. These are the conditions which need to be investigated genetically. So there are genetic tests given on the right side. If there is no endocrine abnormality seen, then in such cases we need to go for the chromosomal analysis. This is simple. So from genetics perspective, we need to look at whether she is having a specific condition, especially in cases of the endocrine imbalance, whether she is having a specific genetic disorder, identifying that by doing a particular test, and then counseling regarding the appropriate treatment modality. In case of male, there are two important investigations. One is the semen analysis and second is the hormonal assay. In case of semen analysis, if the semen parameters are abnormal, showing azoospermia or oligospermia or teratospermia or acinozoospermia, there are different reasons for that. So here we can look at the different investigations given. One investigation which is very common in case of male is karyotype. Most common investigation, oligoazoospermia is karyotype. Then you can go for the microarray analysis, you can go for the single gene testing. In cases of endocrine abnormalities, if it is because of the low testosterone level, there is hypogonadotropic hypogonadism, or it could be hypergonadotropic hypogonadism. So depending on that again, the different kinds of investigations are done. So the common investigations in case of male oligo or azoospermia involves karyotype analysis, cystic fibrosis mutation, because absence of vas difference, bilateral or unilateral is one of the common conditions. Y chromosomal microdeletions, these are the common investigations. The other specific investigations, after these basic are done, if these are not showing any abnormality, the other specific investigations will definitely help. Here are two case scenarios I am taking which actually show the role of genetics in infertility. So you can see here a pedigree showing a couple, man Sarang 35 years and a woman Soumya who is 32 years, married for last 3 years, and having a history of 2 miscarriages, and then they are trying for the conception, she is not getting pregnant for more than 1 year. This is the scenario. Now Soumya and Sarang both are not married consanguineous, they are not in consanguineous marriage. Soumya has a short stature, about 5 feet only. She has a history of CHD, the congenital heart defect, for which she was operated as a child. She also has a history of mandibular dysplasia, for which she underwent the surgery when she was a child. Sarang also gives a history of congenital arthrogryposis, and they are trying to have a baby. Now in this scenario, we did advocate the tests, karyotype of both husband and wife, and then the carrier genetic testing, whole exome sequencing of both husband and wife. And we could found that Soumya is a carrier for one of the pathogenic gene, which is autosomal dominant with a chance of 50% inheriting in each subsequent pregnancy. And Sarang also is having a carrier for 2 pathogenic mutations, very rare scenario. So I am showing this because this is explaining one of the conditions, right? But this is very rare scenario. I am explaining both husband and wife are the carriers for autosomal dominant condition, and one person is having 2 autosomal dominant disorders. So Sarang is having two autosomal dominant conditions, of which one is responsible for arthrogryposis, that he was having, and another is responsible for spastic paraplegia. Now, in such case, if they go for pregnancy naturally or even with advanced reproductive technology, what are the possibilities? Just look at that. Questions to be answered are, what are the chances of inheritance for each individual pathogenic gene? 50% chance for every gene, okay? Autosomal dominant it is. What are the chances of having a normal baby? Now, in this case, if you really calculate, it is not more than 12.5%. 12.5% is the maximum chance that they can have a normal healthy baby if they undergo pregnancy. What are the chances of having only one pathogenic mutation? What are the chances that all three pathogenic mutations will be seen? And what are the reproductive options available? So here you can see the different options that I have considered. Yeah. So if you look at this, the available option, the reproductive options are natural pregnancy. They can go for natural pregnancy and then go for the prenatal diagnosis. But in such case, as I said, the chances of having a normal baby are only 12.5%, meaning the chances of having the abnormal baby, at least one mutation, are 87.5%. Intrauterine insemination. So if you are using the sperms from the other man, his genes are ruled out. So still, some man is a carrier for one pathogenic mutation, 50% risk in every pregnancy. There are 50% chances with donor insemination also. If you go for donor egg, his sperms with two mutations, very high chance of having the abnormal baby. So even with reproductive technology, the possibility of having a normal baby in such cases is too much reduced. So you can see here the possibility is given. 1 in 8 chance of having a normal baby, 3 in 8 chances of having a baby with one pathogenic mutation, 3 in 8 chance of having a baby with two pathogenic mutations, and 1 in 8 chance. So there are all three pathogenic mutations in the baby. If you use the donor egg, some has, so you are taking other eggs, so the possibilities are 1 in 4 having a normal baby, 2 in 4 having the one pathogenic mutation, and 1 in 4 having the two pathogenic mutations. Donor insemination, here the possibilities are given 50%, 50%. Case scenario 2. Now in this case, as you can look at, this couple has been married for the last 6 years with 3 miscarriages with natural conceptions and 2 miscarriages with IVF, 1 baby birth with IVF, and this baby born was having mental retardation and died. And then again they were trying to have a conception and she was unable to conceive. So this was secondary infertility with 1 child death, male child death. Now when we investigated this child before the child died, still then nobody was, none of the abortus was investigated, the couple was not investigated. We advised the karyotyping and the whole exome sequencing. We found that this baby was having Omen syndrome. Omen syndrome is autosomal recessive genetic disorder. There was a RAC1 gene. Okay. So Omen syndrome is one of the autosomal lethal disorder where there is a, you can say, deficiency of the immune system. Right? Very so severe that the baby will die within few days after birth. Immediately there will be immunological attack. So when we did the karyotype, now surprisingly this is one of the again very rare case. Just to explain you what are the possibilities. Here in this case you can see the lady is showing a translocation between chromosome 11 and 18. Balanced translocation between chromosome and 18. And at the same time, when we advised the whole exome sequencing of the couple, both husband and wife, they were having the pathogenic mutations. Do we have a point? Can you click from there?
Yeah.
Both were carriers for the mutation in RAC1 gene, which was responsible for Omen syndrome. So now, Omen syndrome, both being carriers, autosomal recessive का मतलब है दोनों जीन अगर खराब रहे तो ये बीमारी होगी. अब इसमें ये दोनों husband wife एक ही mutation था, दो carriers से उनको प्रॉब्लम नहीं था. But in every pregnancy there is a possibility of 25% possibility of having the baby with Omen syndrome. And with this translocation 8 and 11, the possibility of having the abnormal conceptors in every pregnancy is about 50%. So 75% possibility, if we add 75% possibility, they are going to have either abortion or the abnormal baby birth. Only 25% chances that they can have a normal child. Right? Now in these cases, so they have undergone 3 IVF without any investigation. And unfortunately in IVF she conceived, she had a baby and the baby was abnormal and the baby died. So this is what can happen when we are not investigating from a genetic perspective. Why I am stressing upon this is, nowadays, because of the information being available everywhere, patients are so smart and they are studied. If you don't do this, and if something happens like this, baby is born with genetic abnormality, this becomes a legal case. Right? So you did all and the baby is born and baby is abnormal, or the baby dies because you didn't investigate. And investigations are available. And this is one of the recommended investigation. So you have to actually recommend. They might do, might not do it. You have to recommend that these are the tests to be done, which can give us an idea about whether you are at risk of having the abnormal baby birth. Do risk exist? Yes. In IVF, ICSI and the other modalities also, definitely there are risks. So that involves counseling. Before treatment starts, every couple should receive updated information on the risk of transmitting chromosomal aberrations, risk of de novo normally sex chromosomal anomalies, especially because of the procedures. There are a number of reports showing IVF, ICSI results into increased incidence of chromosomal abnormality, especially de novo abnormalities. Risk of transmitting fertility problems to the offspring, like in cases we have seen Y microdeletion, definitely they are going to transmit to the child, male child especially. Increased incidence of congenital malformations. Again, there are reports showing there is an increased incidence of congenital malformations in babies born ICSI, especially ICSI. Importance of the personal and family history in infertility. Definitely you can ask some of these factors. So you can ask for if there is any pulmonary or digestive problem, they have a respiratory problem or any digestive problem, which gives us idea about whether they are likely to have the cystic fibrosis or whether they are likely to have the immotile cilia syndrome. The history of hypogonadism, actually history along with the examination is required. So in such cases, you can check for the Kallman syndrome genes and partial androgen resistance genes. These are the available. Neuromuscular symptoms, the Kennedy disease, which is one of the muscular disorder, and sphenoid myotonic dystrophy, which are also responsible for infertility. So if you are having a muscle weakness along, you must ask the family, and then that helps us actually to prevent the birth of the abnormal babies. This is that we need to keep in mind. Most of the genetic disorders which are lethal and do not allow the person having the disease to reach even the reproductive age. Consider, for example, Duchenne muscular dystrophy is a common condition. Most of the boys will not marry. Nobody will marry them. By the age of 20, 25, most of them they die. So most of the, you can say lethal, the genetic disorders, they stop by reproduction. They don't reproduce. But still there are conditions which are not seen. Like autosomal recessive disorder, there are 14,000 disorders which are inherited. 14,000, 4,000. And you don't have any access to test them. Unless and until you actually focus on the history. In cases of consanguinity and close relationships, we must go for the genetic analysis so we can pick it up. What forms of male infertility are left to cure? So if you look at the male infertility, especially Y chromosome microdeletions or XXY conditions, they are very likely to reproduce. But now we are very smart and we have started with all those advanced technologies, and still we give birth to the babies, to those men having no ability to become a father. So these both the statements, these are the statements of 1995. I must stress upon that we are so advancing. That time it was true. Now it is not. It is advanced so much. And tomorrow we will talk about we will be manipulating the genome. So nothing is stationary. But the most important thing stationary is there are complaints, people come to you with hope, and you have something in your hand. You are the expert. They look at you with very, you can say, too much of faith and trust. So just be what you say who you are. You say you are a doctor. You are here to deliver health. Just get present to that and deliver that, which involves whatever is available, right? So with this, I would like to end my talk. Summary: infertility involves genetic factors like chromosomal abnormalities, single gene mutations, and polygenic inheritance. New genetic testing methods like next generation sequencing enhance infertility diagnosis accurately. Personalized treatment such as in vitro fertilization with pre-implantation genetic testing improves conception for genetic infertility. And ongoing research aims to develop better diagnostic tools and therapies through interdisciplinary collaboration. So all people from all pathies can come together and they can collaborate in various aspects of infertility treatment, especially even the Ayurveda people, homeopathy people. They are doing the treatment for a very long time, right? So you can come up and join the advanced teams and do whatever is better from your side. So with this, I would like to thank you all for your patient hearing. If you have any questions, I would love to take those questions.